Good afternoon. Thank you so much for your attention thus far and for continuing to participate with us today. We are going to continue on, and I'd like to welcome Dr. Bill DiScipio to the stage as he's going to talk about strategies to prevent provider burnout. Dr. Bill is a clinical psychologist with New York Blood and Cancer.
Thank you very much. Thank you all for coming today. We're going to solve burnout today. Okay, here we are. There's no fire. It's just the healthcare workers burning out. Okay? But you know, where there's smoke, there's fire. And where there's fire, there's ignition. So there must be something more to burnout than just a smoke out of a hospital. So let's see if we can try to explore that. I want to try to sort of give you an overview of where this came from, the term itself, you know, how we can better define it, and therefore how we can either treat or prevent if that's possible. Okay, now this is not for you to read too easily. This was for the ophthalmology conference, but in any case, it is a survey. Quite a large survey was done by Medscape online of over 13,000 healthcare professionals. And if you're looking very carefully, or I can just tell you that oncology is right in the middle, 42%. These people were asked, do you experience burnout? Without definition, it was just a term. If you look at the distribution, it's not really too wide. It ranges from about 29-30% to 54% of professionals in all of these specialties who claim they experience burnout. Okay. I should say this might be very time dependent because I think the survey was done over the COVID period. Okay, so where did this word come from, burnout? Well, it was coined in the 1970s by an American psychologist named Herbert Freudenberger. Interesting name. Huh? It had nothing to do with Sigmund. He used it to describe the consequences of severe stress and high ideals in the helping professions. Doctors, nurses who sacrificed their lives for others would often end up being so-called burned out. That means exhausted, listless. This is what he was writing in his book, and unable to cope. Nowadays, the term is not only used for helping professions, but also for the dark side of self-sacrifice. It can affect anyone, from stressed-out career-driven people and celebrities to overworked employees and homemakers. Some of the surveys I've explored, here we go, show a lot of burnout issues among teachers, especially these days. Well, okay, now burnout as a term was included in the World Health Organization's 11th revision of the International Classification of Disease, ICD-11, as an occupational phenomenon. It is not classified as a medical condition. I think we should make that clear to begin with. Burnout is defined in that classification as a syndrome. Already we're starting to sound medical, even though we just said it isn't a medical condition. Conceptualized as resulting from chronic workplace stress that has not been successfully managed. We all have stress, but sometimes we don't manage it properly. Surprisingly, experts don't always agree on what burnout actually is. This has consequences because it is not exactly clear what burnout is and how it can be diagnosed. It is also not possible to say how common it is or even what to do about it. I often say to interns and trainees that diagnosis is a sine qua non for treatment. That is, without which nothing. If you don't have the right diagnosis, you cannot find the right treatment. Okay, so we're going to live with this term, burnout, all right? Let's see what they did in IC-10 and IC-11. They defined it into three categories: exhaustion, alienation, and reduced performance. Okay, just to keep it in the context of a job-related difficulty. People suffering from exhaustion, unable to cope, they feel tired all the time. Physical symptoms include GI tract problems, and this is probably where we would use the word fatigue, which is again vague difficult term to define. Alienation from work-related activities. People who have burned out find their jobs increasingly stressful. They may start being cynical. It's a word we're going to see a lot in literature. There's been maybe 4 decades of literature on burnout, and many popular books on it too. At the same time, they may be increasingly distance themselves emotionally and start feeling numb at their work. Now, this is starting to sound familiar, because this sounds like depersonalization. Okay, and then lastly, reduced performance. And this is one of the ways that we try to define or give it a context in some reality-based way. Tasks at work are not done. Oh, now I got to go back. All right. Well, the tasks at work are not done completely. Now I'm about 6 slides ahead. How can I get back without touching anything? That's good. Okay, we can stay right there. Thank you. See, I always have help. Women help me all the time. I'm just confident. Okay, so reduced performance at work, where people are feeling very negative about their tasks. They find it hard to concentrate, listless, and lack creativity, whereas they may have been very good at that in the past. Okay, carefully going to try. Now, how can we measure in some objective fashion burnout, which in psychiatry is an interesting question, because if you don't have the diagnostic tools that are so empirically and scientifically based, we don't do blood tests and so on for many psychological conditions. So there was a scale that was devised a while back, actually 40 years ago. It was called the Maslach Burnout Inventory. And these are 4 questions that it basically asked in the inventory. How do you perceive your work? Are you exhausted? How capable are you of shaping your relationship with others? Very important to see what the context of the social setting is. And to what degree are you personally fulfilled? Now we start to get into values and where we are in a career. Okay, this is the Maslach Burnout Inventory. It was devised by Christina Maslach from the University of Berkeley in 1982. There are 22 questions here, and scaled, and it has scoring. If you want to look at this, it's helpful. These types of scales, as in all psychiatry, psychology scales, have a lot of face validity. That means they are what they look like. They don't necessarily have predictive validity or construct validity, or, it's much more difficult to come by that. But for example here, the number 1 question is, I feel emotionally exhausted because of my work, and that's scaled. And look at the opposite, question 12. I feel full of energy. So this scale tests both the downside and the upside. Can people have any resilience to burnout, or just how burned out are they and in what categories? Now these are the these are the factors. How do we get it back? There we go. Magic. These are the factors that Maslach defined. She tried to throw them into 2 categories: occupational exhaustion and depersonalization or loss of empathy. People that are not very friendly and not pleasant to work around. The other factor that's measured by that scale is called the personal accomplishment scale, and that gives you some idea of how well the person might be adjusting to dealing with factors that are causative of burnout. Okay. Now, I've come up with a broader view of burnout, and I think it's more than what Maslach measures. And I've come up with these 5 categories. I'm a fan of factor analysis, and I hope someday I can get a grant to factor analyze these factors. But so far, this is a hypothesis that burnout may be contributed by these factors, may be a function of these. They may be overlapping in some way, they may be intercorrelative, but I think this is the range of ideas that we might cover what the phenomenon is. One is depression, simply depression. Another is a career crisis. Another are personality factors or cognitive factors that might contribute. Toxic work environment, very important, toxic work environment, and what's known as compassion fatigue. So let me get into each of these a little bit more. And now, as we know, depression, which we've known for a long time, and it's been classified in not only the ICD, but also in the DSM, the Diagnostic Statistical Manual for Psychiatrists, which do not have burnout in that manual. But here are some factors of depression: anhedonia, symptoms, negativism, cynicism, reduced efficiency, mental physical fatigue, somaticism, depersonalization, and insomnia. Sounds like burnout, okay? But those are often associated with depression. So let's look at some of the literature and see if there's any empirically based studies to help us with this. Burnout, and depression, two entities or one? So I've just subjectively selected a few studies here that seem to be contributory. And here we have a study published in 2015, which was actually, the sample comprised 1,386 school teachers. I mentioned before that it's very prevalent among school teachers. I picked this because there was such a large sample size from 18 different states. And if you jump to the italics in that second paragraph, the study provides evidence. Okay. Here we go. Figured out how to handle this. The study provides evidence that past research has underestimated burnout-depression overlap. The state of burnout is likely to be a form of depression. That's the conclusion of these authors. Given the magnitude of burnout-depression overlap, treatments for depression may help workers identified as burned out. Okay? So that's the finding of this study. To get into it a little bit more detail, you can see the correlations there, 0.77 and 0.84 between burnout and depression measures. These are different statistical measures with using rating scales. So that's like 49 to 60% of the variance is in common with these scales. So there certainly must be an overlap between the idea of a depression, a clinical depression, of whatever variety that might be, and this idea of burnout, okay? One other study finds just pretty much the opposite, and had used the Maslach scale and correlated it with depression, the depression scale, and had one they picked out, and argued that studies confirm that burnout and depression are not independent, claiming they are simply the same mental illness that is not supported by the accumulated evidence. Okay, and there's hundreds of these studies that are somewhat ambivalent, but they come back to the idea that we haven't defined the term in the first place. So why would we expect any consistent results? Okay, now here's little conclusions that I'm drawing just to put us in a ballpark and give us some context. In depression, negative thoughts and feelings aren't only about work, but about all other areas of life. Other typical symptoms of depression include low self-esteem, hopelessness, and even suicidal ideation. One of the scales we use, the personal health questionnaire, the last question, number 9, is, do you think you'd be better off dead? And that's kind of a real signal that you better be looked at a little more carefully. Is that suicidal? And that's not necessarily correlated with this idea of burnout. So I've concluded people with burnout, this is a result of looking at this literature and well, at least my 15 years of experience with oncology and 55 years of experience since my degree. People with burnout don't always have depression, but burnout can certainly contribute to depression. That's the conclusion. All right, I'm moving to the next slide here. How does career crises contribute to this idea? Well, I looked at that study of the 19,000 professionals, healthcare professionals, and this is one of their other slides, results they produced. And they found that 60% of the respondents in this, something like 69 different healthcare professions, responded that too many bureaucratic tasks were correlated with them feeling a sense of not coping with their job well. Second was too many hours at work. Third was lack of autonomy and control. That's an important factor, control and autonomy. If we jump to preventive measures or treatment measures, Obviously, the things to do here would see if you can reduce the bureaucratic tasks. We try to do that all the time in our agency. Delegating more to another team in the agency or assistants. Too many hours at work. Well, we tend as medical professionals to take on too many hours. We don't just think of a 40-hour week. We do whatever the week requires. So we have to think more about not doing 12-hour shifts, 3 days a week and so on. And lack of control and autonomy, that comes from people who work in corporate cultures, for the most part. Other categories here included interpersonal crisis, people complaining at 40%, the lack of respect from colleagues, and the lack of respect from patients. Now, I should also mention here that a lot of these factors are contingent on the time in career. We don't expect people to be burned out of college, but we do expect them to get into this more of a crisis of, maybe it's even an existential crisis, by the time they've 30 or 40 years in a practice. So that, I think, is another factor. What are your values by that time? Have you lost control and autonomy? Do you feel you're less effective than you were in the beginning? I see a lot of patients that complain about that. They're professional patients. Financial barriers, that's kind of common, 28%. And finally, corporate fatigue, which is really a different concept, but I would include it in this general burnout conference. A third category, do personality factors contribute to burnout, or cognitive factors? Do they contribute to burnout? Oh, you still have the slide. I'm losing mine here. That's fine. Okay. These are concepts from psychology that have had a lot of empirical validation that I think are quite reliable and a good context to think from. For example, one of the, I don't cover them all, but here's one idea. Internal versus external locus of control. Can that contribute to a person feeling they're at the end of their career, having difficulties? Psychologist Rotter in 1966 stated that when we place the locus, where we place the locus will either reinforce or punish our actions. An internal locus of control will lead to reinforcement of that behavior, and the behavior will continue. An external locus of control will cause the behavior to extinguish. Why would we continue to try if the outcome is outside of control? So to sum this up in this other sentence here, if we place locus of control as being externally determined, we are likely to blame the outcome on fate, luck, or happenstance. It's never my fault, it's always what someone else does. The problem on the job is my supervisor. Problem is, there's too many patients. But if a locus of control is internal, we're likely to believe that our own actions determine the outcome. And this is clearly a personality typology. We fall somewhere in a dimension of these concepts, but there are people at extremes too. And we might want to consider that in terms of how we cope or prevent burnout. Okay, other ideas in psychology. The concept of learned helplessness, a very simple concept that I found is super effective in understanding when people don't respond well. This was Seligman, a psychologist, who subjected to study participants to loud, unpleasant noises, and they had to press a lever that would occasionally stop the noise and occasionally not stop the noise. Now, the issue here was that they couldn't predict when they were successful, and any time outcome is non-contingent. These in animal studies to human studies, it leads to non-responding. It leads to a kind of a extinction program. I no longer want to respond. I have no idea. Sometimes it works, sometimes it doesn't. I give up. That's called the learned helplessness hypothesis. And another idea here, another different one, is called cognitive dissonance. Probably heard of this some places too. And this is a state of mind where you're holding at the same time inconsistent or contradictory thoughts, beliefs, or attitudes, especially as relating to behavioral decisions and attitude change. A simple example of that is, I'm a doctor, I don't get sick. Who's going to treat me? Why should I be sick? Why should I experience this? I'm above this, and I should know how to deal with this. I should have a lot more going for me. That's cognitive dissonance, okay? Which of course raises anxiety. And if you have enough anxiety, you will also have a depressive syndrome too. And I've also listed in these factors contributing to burnout, toxic work environment. I think we all know what that is by now, where negative antagonistic or bullying behaviors defines the work culture. In toxic work environment, employees are stressed, communication is limited, blame is rife, people are rewarded tacitly or explicitly for unethical, harmful, nasty attitudes and actions as ignored or punished, or they're punished for altruism. And this is another talk, but I should add here that the gender difference, that when women are surveyed on burnout, they might respond in the high as 60%, whereas men will respond at about 40% of feeling they're burned out. So there are many more issues that complicate women's perception of where they are in their careers. And obviously that would probably have to do with factors of they're holding on to two careers, raising children and having a career, or there's the glass ceiling, which we're doing some work with these days, but there's always an issue of discrimination. So gender is an important consideration in this burnout hypothesis. Now lastly, this fifth factor, compassion fatigue. It's a state of tension and preoccupation with the client or cumulative experiences of clients as manifested in one or more ways, including re-experiencing a traumatic event through avoidance or numbing of reminders of the event and persistent arousal. Although similar to critical incident stress, it's a form of trauma. It can be thought of as secondary post-traumatic stress. And we're all pretty much aware of the issues of stress these days, especially PTSD, which could be a possibility of a defining burnout in these traumatic fashion, which result in these numbing experiences. Okay. So some preventive options that might come to mind, and this is a personal view. I think first and foremost, we must do self-assessment at all time in our career. We must bring into play our values and our beliefs. Are we in the right profession? Are we as effective as we would like to be? Do we come up to the ideals of or the performance of our peers without being super competitive? Do we believe in our profession? Will there be a cure for cancer? So I think we have to start with that and then look at where we are in our career and then see what might be going on that are negatively impacting our performance on the job. A second factor here is preventive, is career work environment assessment. Look at our jobs, look at what's going on. Is it the right setting? Should we change our jobs? Should we talk to our supervisors? Should we change the roles we have in the jobs? Should we change our beliefs and attitudes toward the job? And if we are found to have a strong component of depression, and I'm going to suggest some scales that we can use as professionals to see if we are feeling depressed in a formal way as well as anxious. If we do see that we're starting to look like a depressive syndrome is developing, remember my idea is that depression can be a function of, can be an outcome of burnout, well then we might be eligible for an SSRI or an SNRI, which are very effective drugs these days. But we certainly want to consult with our specialists in the professions that we work, in allied professions that we work with. We may need sedatives to deal with sleep, because sleep is disturbed and often in these times of stress. And another factor here is psychotherapy. I think we all know CBT, cognitive behavioral therapy. It used to be called behavioral therapy. The cognitive component was added to it. And this is where we do things like things that I'm doing now, talking to people about reframing what it is to mean to be burned out and what we might do about it. Often in most research of efficacy, psychotropics and psychotherapy are most effective if used together, especially in severe depression. And then you have another category here of preventive options, and that's peer counseling. This is a reference to a physician who started a peer counseling website where it's kind of simple but interesting. He simply asks you to report bring in a colleague or a friend, and the two of you sign up and you go to this website and you're able to set times to talk to each other, maybe every week and every month. Now, we're doing something here that I just found out about having gotten involved in this conference, and it's a program to bring together professionals on a much more complex platform. And I'm hoping that that will develop into something that might, enhance cross-disciplinary communications. And bring in more of our mental health professionals to talk with our oncologists. It's called Slack. Okay, this is a plug for OneOncology. And Dr. Daniel has been working on this program, Slack. There's a desk outside you can check with, see if you want to sign up for Slack to get in touch with other professionals. Okay, and lastly I have on here is so-called preventive measure, quiet quitting. I think some of you must have heard about this. This is where people work to task, where they say, I can't deal with this job anymore, I'm just going to do what I have to do. And that comes to play when we find out that we're the overworked people, we're the people that want to take on more. We stay till 12 o'clock or 10 o'clock if we have to. And if you are feeling you're burning out or something is going wrong, you can try to pull back and say, I'm just going to work 9 to 5, and that should be sufficient. But it's not a cure, and it's not something that I'm proposing as something you jump to right away. Okay. Now these are some simple ideas that I've seen after reading so many of these popular books. They seem to all come to the same conclusions, and they're very simple, and I mentioned this already. On the preventive side, review your values and your meaning and purpose in your career and in your life. I often say to patients when they first see me and they've just been diagnosed with cancer, what are your values? You think you're going to live forever? What is meaning and purposeful in your life? And then I try to identify the specific problem, maybe using some of the different categories I've outlined. And here is some practical advice. Get in routine exercise. I'm always advising patients to exercise, but their concept of exercise is often they have to be an Olympic swimmer or something, or they have to run the marathon. I've been finding that something like restorative yoga, which is a special form of yoga, is very helpful to reduce stress, and it's something we can do routinely every day without having to go to a gym or anything like that. It also includes a relaxation component to it. Get enough sleep. Sleep has been almost 80% of patients I see are telling me there's some form of disturbance of onset or awakening or daytime sleeping. And that's going to contribute to the stress, to the depressed ideation, to the anxiety. And I'd add diet to this too. We have our own dietary department too. Okay, stay connected. And that means talk to your colleagues. Find colleagues you can trust. Talk to them in other agencies. Use networking of some kind, that one website I suggested, or the one that we're building called Slack. Reach out for help. We all need help sometimes, even though we are at the top of the totem pole here, we still need to have help. Know you're not alone. Prioritize teamwork and peer interaction. Some of the empirical research that's come out in this area have really come to conclusions about the teams, the importance of being connected to a team, not being alone in an agency. And obviously avoid substance abuse and stay curious. I often find that if I ask patients who start with me because they've had a medical diagnosis, cancer or hematology issue, I ask them, are they smoking, are they drinking? And they say, yeah, and they say, maybe, weekend, so on. I ask them to start a log, and I want to know exactly when they're drinking and what time, what place, for a week or 2 weeks, and I'm not asking them to change anything. And it gives me a very good idea of how they might be using non-prescriptive medication to self-medicate. And then I can begin to think of, do you need something else? Is there another way you can do that? Another way that you, instead of having that drink at night, that you can use meditation or get more sleep and so on. And that would mean a consultation with a psychologist might be the best way to kind of bring that all about. Okay. These are references for you guys. The survey was taken, the quotes I had from all those surveys was from that Physician Burnout and Depression report in 2022, but it was done in two years prior. But the MBI is online. You can find that quite easily. Take the scale yourself, score it for yourself, and see what insights it might give you. We use the PHS-9 for all patients, which keeps us on the burnout spectrum, because so many patients are in need of help with depression. 10% of 2,000 to 3,000 patients that we've given this survey to score over our cutoff of 10 and show they're depressed. And I would imagine if we gave this to staff, we might see that too. And it can be, you can use it yourself. It's only 7 questions. You can look that up online. The GAD-7 is the Generalized Anxiety Disorder Scale. There's only 7 questions in that. And that'll give you some measure of your degree of anxiety, distinct from depression. These are correlated syndromes, but it would help to sort them out, personally, sort of like a personalized medicine, to figure out whether you need an antidepressant, an anxiolytic, or SNRI, if you have to go the route of medication, because you're, really feeling down. Okay, I think I've done it. Do we have any time left? Okay. All right, thank you very much for listening. I'd be happy to answer some questions, and I would be available after the show or at any time. I'm in the network, and if you want a consultation with me at any time, I'd be glad to do that collegially. Okay.
Thank you very much.
Okay. All righty. Thank you. Enjoy the conference.